So for this evening's presentation, it's COVID-19 from the front lines of the Colorado nursing facilities. We're joined with Dr. Leslie Eber, Allison Villegas, Travis Neill, and Dr. Singh Palat. So I'm going to turn it over, get everybody unmuted here on our panelists, please. And I will turn it over to Dr. Eber to tell you all a little bit about herself.
Oh my gosh. Hi, I'm Dr. Leslie Eber. There's a long paragraph which you don't have to read. I am a practicing geriatrician in post-acute and long-term care. I'm medical director of facility, and I'm also the president of CMDA. I'm thrilled to be here. Next slide, maybe.
Hi, I'm Allison Villegas. I'm a physician assistant. I've been working in the post-acute and long-term care setting for the last 8 years. I'm also a member of the CMDA board.
Hi, I'm Travis Neill. I'm also a PA, been working in post-acute care for 10 years now, and on the CMDA board. I think something relevant to this conversation is I've also been involved pretty heavily in antibiotic stewardship efforts at about a dozen nursing homes. And as a result of that, involved in a lot of infection control practices. So that has been a big part of my career for the past 3 years, and looking forward to it.
Hi, I'm Singh Palat. I am a geriatrician and attending physician and medical director, most recently with Life Care Physicians in Lakewood. I'm really happy to be here today on behalf of both the Foothills Medical Society and CMDA, the Society for Post-Acute Long-Term Care. Ready to start?
Let's go.
Yeah. Well, I brought this slide up because nursing homes have definitely been in the news recently with COVID-19. Here are some recent headlines that I saw when I was browsing. The New York Times says that nursing homes are death pits. Kaiser Health News says that COVID-19 lurks. Then families are locked out of nursing homes. Is it safe inside? And Colorado Public Radio reports that infection control and other steps are failing. So basically all these headlines report that nursing homes are full of death and failure. Is that what we want the public perception of nursing homes to be? Of course not. In the next slide, you will see the vision from AMDA, the Society for PALTC. So you're going to hear us talking about nursing homes, nursing facilities. Well, PALTC is a term that encompasses post-acute long-term care, basically all facilities from independent living to group homes, assisted livings, nursing facilities, and places that provide rehabilitative care. And if you talk to people who actually work in some of these facilities, like the people on the panel today, like several of you who are on the call, you will find some people who are actually often very highly engaged. Many of us strive every day to try to ensure that the standard of care is met or exceeded for our patients. And many of us are called upon to advocate for patients in PALTC. On the next thank you. On the next slide, you'll see the goals for today's webinar. Each of our panelists are going to present one of the topics. So I'll go ahead and hand over the mic so we can start with the first one, which will be presented by Dr. Leslie Eber.
Thank you, Singh. And our first goal is to talk about the what's going on in Colorado. So CDPHE, our Colorado Medical Department, prints out every day. You can go and see the update and what's happening with COVID-19 in Colorado. And this is data that is for today. And so as of today, 20,838 reported cases with 179 new cases today. And unfortunately, we've had 1,091 deaths, with actually, I think it is 53 new deaths today. So we have to do that differently. And then they have some data, which is, and I'm just going to move something over here. Okay. Which is for residential and non-hospital healthcare facilities. And that's really nursing homes, assisted livings, as well as jails, even dairy farms, all of those types of facilities that are not hospitals. And we have 208. Oh, I think that something happened to my slide here. I'm not sure what. Stephen? Ah,
Yes,
thank
ma'am.
you. So 208 facility outbreaks in Colorado, with 2 new facility outbreaks reported yesterday. We have, in terms of hospitalizations, 3,789 case hospitalizations, with 32 new hospitalizations yesterday. So those numbers are pretty concerning, but I think we need to dig deeper and find out what they actually mean. So next slide, please.
Did you want to go ahead and do your poll, Dr. Eber?
Oh, yes. Can you put up the poll question just so I make sure I answer? Okay, so what percentage, this is a poll for everybody on the call, what percentage of COVID-19 deaths in Colorado occur in post-acute and long-term care facilities, nursing homes and rehab facilities? And your choices are presented: 13%, 28%, 57%, and 64%. And you can just click on one. I guess I'll click on one too. I kind of know the answer, but, and then let's see what everybody said. Can we see that?
You can. We're at 12 of 19. Let's see if anybody else get your vote in here. Getting a few. 14, 73%. Last call for voting. All right.
Okay, so most people got the right answer. 43% picked. 57% of the deaths in Colorado are attributed to nursing homes, and quite a few people also picked 64%. But we have to think about what that information means, because our ability to test in Colorado has been quite limited, whereas our ability to test in nursing homes in Colorado is growing. And so when we look at other states compared to Colorado, often their deaths due to nursing homes are going to be much smaller because their testing outside of nursing homes is much larger. So let's kind of tease this data apart and find out what this data means and how could we use this data to decrease the mortality and morbidity here in Colorado in our nursing homes. And so we first have to understand that this data looks at a single point prevalence. So when you go to CDPHE, to the website, you can also look under the outbreaks, and it will give you a lot of different numbers. It will tell you the number of residents in a particular facility who has COVID-19 positive, and they'll tell you the number of probable COVID-19 positive patients, the number of deaths in that facility due to COVID-19, and even the number of staff who are positive. And so we want to try to use that data in a meaningful way to make a difference. So we'll know that this is a point prevalence, and what we don't know about this data is this a series of tests done in this facility, or is this a one time that they tested maybe many people in the facility, but that's not really clear. And it also begs the question, how much testing is being done in a facility? And so we know that in the state of Colorado, 2 positive COVID-19 tests in a facility equals an outbreak. And some facilities will just stop right there. And even though they're trying to measure the probable COVID-19 infections in a facility, of course, the patients who are asymptomatic will not be measured with that measurement. And so there'll be a lot of variation with when you look at facilities and how many positive patients they have, depending on how much testing they're willing to do. We also don't understand what the denominator is in these numbers. So if a facility has 10 positive, is that 10 out of 20 patients, or is that 10 out of 150? And that's going to be a very different situation for that nursing home. And then what is the relative community prevalence? So if a community is undergoing a very large COVID-19 infection, we know that that will seep into that nursing home. And it's really important to know that even nursing homes who have amazing, outstanding infection control, COVID-19 is like catching the wind. Of course, we've been considered ground zero of COVID-19 infections. We have the most vulnerable populations, and we're living in very, very tight, close quarters. So we're definitely that perfect storm. But because a lot of the spread is through asymptomatic staff members and residents, people who, facilities who have great infection control can still have an outbreak. Next slide, please. Thank you. And so also, what are the unintended consequences of this data? And of course, there is some fear from facilities to test at all because you end up on this website. I go to 5 different facilities, and I've had the full gamut. I have one facility who tested everybody, and I've had some facilities who just did 2 or 3 tests and that's it. And another unintended consequence is that staff may not come to work. They may look at this data, or they may find out that there is a lot of COVID-19 infection and become very fearful. And we've seen that in other states, but not that much in Colorado. And I think that's due to some of our education that we've worked really hard on. And then there's fear from the public, as we saw from Dr. Palat, all these kind of terrifying headlines from newspapers and news reports. And that, of course, has an effect on families and residents and the staff themselves. But I think the most important thing that we have to think about is what comes next. We have all this data, but if we're not prepared to use it in a meaningful way, then we kind of wonder why we're doing this. Next slide, please. Next, thank you. So what are the lessons learned from the past few months in the state of Colorado with this data, with some of this knowledge? How can we move forward to make a difference in our facilities? And so, as I said, I go to 5 different facilities, a medical director of 1, and I've gone through that total gamut of testing all residents and all staff, and then testing a few residents and a few staff. And so what I think we could gather from these experiences in Colorado is that testing is good. Even though if you get just a point prevalence, it's going to help you assess the extent of viral spread. You're going to catch those asymptomatic infections, and you're going to be able to deal with them appropriately. We know that there are false negatives, but even so, we're going to get an idea of how widespread the infection is in the building. Testing staff can really be helpful in preventing the spread as well, because again, you're going to catch those asymptomatic staff members and they'll go home and quarantine, and hopefully that will also help you decrease the spread in your building. As well as PPE allocation. And PPE is still very hard to get, especially in nursing homes. And we want to use it thoughtfully. And if we can understand that maybe if we do testing for all residents and staff, and we see that one nursing station has many COVID infections, but the other 2 nursing stations don't have any, then we can really allocate our PPE to that one nursing station. And it will also help us cohort patients and staff thoughtfully. One of the things that some of my facilities have been able to do is once they realize that the infection is in one nursing station, but not in the other, they really cohort the staff so that they don't mingle. They don't have lunch together, and that can really help prevent that COVID-19 infection kind of jumping from one nursing station to another. We also know, and I think that this is really important, this is something that I've seen every day in the past 2 to 3 months, is that knowing that a resident is positive for COVID-19 really changes staff and provider behavior. And so we see that it's really different to think that a resident may have COVID-19 to knowing that they absolutely do have a positive COVID-19 test. They are more prescriptive in using their PPE and infection control. And I think we also have to understand that our patients present with COVID-19 really differently. So they are not always with the cough or hypoxia, shortness of breath, but sometimes it's just fatigue and some anorexia. And so you could think that this patient might have COVID-19, but once you know, we see that there's really is a big change in behavior. Next slide, please. And so what are some other lessons learned? That supplies and testing are needed. Even though we're ground zero, we're still struggling a little bit for testing supplies. And that it's really important to have a plan after the test. So if you plan to test a whole facility and all of your staff, you need to have the next steps already in place in your mind so that you can, if half of your staff tests positive, what is that next step? We also know that PPE education works. There was just a recent publication in the Annals of Internal Medicine on May 5th that talks about how in-person education for PPE for healthcare workers is really effective, more effective than even the CDC posters, and certainly combining that with videos and posters is even better. And that communicating with your staff is paramount. You have to be honest and address misinformation. If you want your staff to come to work, they need to be valued, and they need to feel that they're safe and that you have their back. And that's going to be very important. You need to be transparent and to be supportive. And finally, you need to communicate with your families and patients. This is also incredibly important for the implementation of some of these things that are really hard to have patients be isolated and not be able to see their family members. Communication with families and patients really allows them to understand what the situation is in your building, and it makes an atmosphere in which you can be more successful in preventing the spread. And then finally, advanced care planning and knowing what your families and patients' wishes are is paramount. This is a very different scene from when they may have filled out their MOSE form. And of course, Dr. Palat's going to talk more about that. So thank you very much. And we'll move on to the next speaker.
All right, Allison, you're up.
I suppose that means I have to turn my camera on. So I'm Allison. I'll be talking about medication routines and symptom management in the post-acute and long-term care setting. So as it says here, deprescribing is a basic tenet of geriatrics. Anytime we have a routine visit with one of our residents, we sit down and look at our medication list and we see what is still appropriate and what's not, because we know polypharmacy presents a lot of risk to our population. But right now, when we're looking at medication regimens, our goals are twofold. It's one, to limit patient exposure to staff, but also to reduce aerosolization. So these are some of the strategies that we're using to limit patient exposure. You can start by decreasing frequency. If you have a medication regimen that is a QID or 3 times a day dosing, what are the logistics, and is it feasible to change it to a twice a day or once a day dosing if possible? Look at and discontinue any unnecessary medications. I always like to start with PRNs. It's not uncommon to find a Robitussin or a Zofran hanging on as a PRN for a patient's med list. I like to discontinue those because if they are having that change of condition where they're asking for a cough syrup or they're having some nausea, I want that phone call about the change of condition. Looking at any non-essential medications like vitamin D, multivitamins, is their iron already supplemented? Do they need that thiamine still? And discontinuing those medications if appropriate. And then reducing glucose checks. And in fact, even just reviewing their entire diabetic regimen is helpful. We don't typically use sliding scale insulin in our setting, but it's not uncommon to see a Humalog with meals, looking at that to see if you can consolidate that into increasing their long-acting dose or even dividing the long-acting dose into twice a day to reduce the finger sticks, which of course require staff interaction, and then of course reduce the glucose checks. And then we'll go and look at our other strategies when we're looking at deprescribing medications. So looking at chronic medication therapies for things outside of diabetes, congestive heart failure, hypertension, dementia, is now a good time to look at tapering or discontinuing that Aricept. Is this medication still efficacious for the patient, or has the risk-benefit profile shifted now? Looking at our CHF patients, if they're on diuretics and your patient is COVID positive and they're having decreased oral intake, you might want to reevaluate the dose of the diuretic that they're on. Consider putting it on hold or even reducing the dose to prevent dehydration. And then some of the other things we do, we look at our psychotropic medications and consider if a gradual dose reduction is appropriate at this time. Look for those protein pump inhibitors, see if we can switch to an H2A. Look at blood pressure regimens. If a patient has been on that same blood pressure regimen for several months and they're stable, but you're still doing blood pressure checks before each administration with hold parameters, you may want to consider looking at reducing those blood pressure checks to really reduce the traffic in and out of the patient rooms, and then of course the use of the equipment. And then the second thing we want to do is reduce aerosolization. And this is where we'll do things like hold CPAP or switch nebulizers to inhalers. Sometimes that second one isn't always possible. If patients are in a lot of distress and they get more relief from the nebulizers, you'll want to continue to use those. I have a patient who's COVID positive right now with advanced dementia, cannot follow cues for inhalers. So we are still using routine nebulizers to help ease his work of breathing. And that's appropriate. You just want to make sure that you're educating your staff on appropriate droplet precautions to make sure that they're in full PPE, including the goggles, gown, and of course the N95. Try and stay 6 feet away while the nebulizer is going, and then of course disinfect the equipment. Next slide.
Do you want to do your poll on the nebulizers?
Oh, I forgot about the poll and I just told him the answer. Oh, this will be a post test.
Yeah.
Yeah, post test. Were you paying attention? You can continue use of nebulized treatments if a patient is COVID positive. Yes or no?
Oh, starting to split a little there, Allison.
Is it? I don't see the results on my screen.
We're almost at 30 seconds. It's the last call for the poll. All right.
All right. Okay, so next we'll talk about symptom management. So, cough, you have your nasal decongestants, your cough medications, but dyspnea is really the primary symptom that we're seeing in the nursing homes. Although Dr. Eber did discuss, we are seeing pretty unique presentations. But if a patient is having shortness of breath and they're hypoxic, of course, our first line is going to be using supplemental oxygen and titrate them up to get the O2 sats greater than 90. They're having pretty significant air hunger symptoms, we can start liquid morphine or Roxanol, typically starting at about 5 milligrams every 4 hours, and you can titrate that for comfort. The next one is fever and pain. As geriatricians, we typically avoid NSAIDs anyway, just because of the effects on blood pressures and renal dysfunction. So we do lean pretty heavily on good old acetaminophen, either orally or rectally for fever. You can also use it for the pain and malaise that they're getting with the COVID. If that's not effective, you can also use Roxanol here as well. To manage excess secretions, really, your first line is going to be positioning, putting the patients into a side or semi-prone position to help with postural drainage is best. We want to avoid suctioning again because of the aerosolization. And you can use things like atropine or scopolamine, but we would exercise a lot of caution with that, just with their anticholinergic properties can cause high risk of delirium, especially in our population. And then the last one is anxiety. Of course, a lot of the anxiety is going to go hand in hand with that dyspnea, and the Roxanol should help with both of those symptoms. But if you're not getting relief with that, we're using liquid Ativan, starting at 0.5 milligram as needed. Again, you can titrate for relief. You can also use Haldol, although in my experience in our settings, I've had more luck on finding the liquid Ativan for available in the emergency kits in the nursing homes than the Haldol. I think now I hand it off to Travis.
All right. Hello. Thank you. Thanks, Allison. All right. I'm doing infection control. I think the COVID-19 virus, if you were Dr. Evil and you were sitting around trying to come up with a perfect virus to take out nursing homes, it might look just like COVID-19. It is a nightmare scenario for nursing homes, not just because of the nature of how the virus transmits, primarily through asymptomatic carriers, but also based on the fact on how a nursing home is set up. So the quick poll question, what's the primary way COVID-19 spreads in nursing homes? We have poor adherence to infection, lack of adequate PPE, asymptomatic carriers, or lack of education on proper infection control practices.
Right, we're coming up on the 45-second mark here. Get your votes in.
Okay, so correct. Majority of people chose asymptomatic carriers. I also put that question in to kind of illustrate the point that even in the best case scenario, if we're doing a really good job in a nursing home, there's no way to screen for and isolate asymptomatic carriers. And the way a nursing home is set up, and if you see the image here on the slide, I superimposed a basic diagram of a nursing home over the picture of a person and their lungs to try to illustrate, give a visual illustration of the fact that nursing homes have these hallways and then central locations that everybody goes to, which is a perfect setup for a virus to gather, and then the vector travels down, like similar to the bronchioles, to the different hallways. We have a ratio of a few staff that do the actual day-to-day care relative to the number of residents. So you have one CNA and nurse for maybe 10 residents. And that means there are hundreds of opportunities, and especially in an asymptomatic carrier, for transmission to occur, even if they're particularly diligent about hand washing and doing basic infection control practices, because there are so many tasks that need to get done on a daily basis to do basic activities of daily living for the majority of nursing home residents. The asymptomatic carrier is the primary vector by which the virus gets into nursing homes and spreads. And then staff often work at multiple facilities, so there's a broad exposure. There is some unfamiliarity with PPE and adherence to it. And even though nursing homes are technically prepared to set up for isolation precautions related to droplets, the idea just, that you can, the basic setup of the nursing home where you have so many tasks to do, and maybe you have one hallway and you have maybe 3 residents that are presumed positive, and you have full PPE equipment sitting outside their room, and you might have to go in and out of those rooms multiple times during the day, in addition to your other duties. The idea that you're going to get it right every single time, and just human nature that you're going to keep doing it and not take shortcuts is just unrealistic. So I think there's just lots of opportunities for us to break isolation protocols. We still, like Dr. Eber said, do not have adequate supplies of PPE in nursing homes. And delayed recognition of cases is the fact that a typical nursing home resident has 2 to 3 chronic illnesses, COPD being one of the more common ones. And so many of the symptoms, the early symptoms of COVID, look just like a bad day for a nursing home resident. So trying to identify what might be COVID related and what is just, a bad day or an exacerbation of their COPD is very difficult. And then our testing problem. And this is, while it's slowly coming along, I would give us a D- as the US healthcare system for getting testing, not just out to the populace, but out to this very frail, vulnerable population. So effective testing strategies would have to be most of, if not all of the staff, and maybe couple times a week. But we could have actually pulled it off by now if we were a little more organized. Next slide. So how do we keep it out of nursing homes? So the main thing is we're restricting visitations. We basically lock down nursing homes, not only to families, but also to only necessary personnel. So we've had to make decisions about who we think is more necessary, and that includes decisions related to end of life and hospice care and physical therapy and home health. And so, nursing homes have handled it differently, but we're significantly restricting entrance to a nursing home. Then we have stations set up at one entrance to each nursing home, and that's where they do the screening of the healthcare personnel, basic questions on symptoms and exposure. And if they answer yes, or they have some of those exposures, a decision is made typically to send them away, and they're gone for at least 14 days, or if they can go get a test, which has been a challenge for nursing home staff. So oftentimes it does mean they're out for 14 days. Our PPE availability and then adherence to infection control practices, like I touched on, is a challenge. And then we want to communicate all the time with the health department. Of course, full transparency for any positive cases, any outbreaks, and then our PPE situation, so we can try to get fully supplied on PPE. And then our testing issue, which is an ongoing concern. Next slide. So now that it's in a nursing home and we know that it's in there, how do we keep it from spreading? One of the primary ways is cohorting residents and staff. So that's taking a hallway typically, or just a certain section of the nursing home, and isolating it for presumed or confirmed positive residents. And we have a station set up at the front of the hallway, and that is manned 24 hours a day. And you have all the PPE sitting there so that as anyone comes in and out of that hallway, they have to don and doff their PPE, and you have someone that hopefully has some expertise in how to do that, who's checking you to make sure you're doing it right and make sure that you're actually doing it before you enter there. That also allows us to cohort staff. So if we have staff that are positive, and we are significantly short-staffed, which is a major problem in nursing homes already, we might be able to get a staff member that's positive to actually work on the cohorted COVID-19 unit. Buddy system is a good way to get the PPE correct. A clean entrance and a dirty exit is basically everybody enters through one part of the building and they all exit through a different part of the building, and they're stationed at both ends. And that just, so if people come into the entrance and they're being screened, but they might be positive and they get screened and they're told to go away, but they touch the door handle, they grab the pen, and so instead of cleaning everything every time, we just want to try to have a clean entrance and a dirty exit. PPE conservation is a big part of our efforts in nursing homes to try to reuse gowns. You can only do that if you have cohorted sections of the nursing facility, and then daily tracking of symptoms and the number of days that they're in quarantine. So our number has been 14 days of quarantine for any presumed or confirmed positives. And then they have to be symptom-free for at least 72 hours before they're let out of the quarantine section. Everyone wears a mask all the time in nursing homes now. That's mandatory. And then vigilant hand washing protocols. This is an area that I've emphasized heavily because I think this is one of the primary ways that it spreads, in that it ends up on a lot of surfaces. And as we all have learned through this process, painfully, we touch our face all the time. So the mask is really about protecting us from spreading it to others, but also from touching our own face and our mucous membranes. And so that's mandatory in nursing homes now, and there's a lot of education. I've also taken a little bit of a stance against gloves, because I think gloves give people a false sense of confidence that their hands are okay and protected now. And in fact, the virus lives better or just as well on gloves as they do on your hands. And so unless you're taking those gloves off repeatedly and putting on new gloves in between your activities, you're not really doing good hand cleaning protocol. So I emphasize no gloves and lots of antibacterial gel. Everybody carries some. There's stations everywhere, and then lots of rigorous hand washing. And then all the commonly used areas, trying to regularly wipe them down on a daily basis, because again, that's a main way that the asymptomatic carriers gather together, spread it to others, and then it starts to move around a building. And then of course our main issue, which is getting testing. And you know, in an ideal situation, we would have blanket testing of all nursing home staff, but you would have to do it at least weekly for it to be effective, so that you identify those asymptomatic carriers. There's a big problem with that. And what happens, since we know this spreads quickly and easily, what happens when you test a facility, say they have 100 staff and 50 of them are positive? Well, you've suddenly lost half of your staff, and you're already understaffed in a nursing home. So now you have a staffing crisis. If we do this across all nursing homes, you might see several pop up with similar situations, and those patients, those residents, have daily needs that need to be met. So I've been seeing every single person in a nursing home, regardless of their job title, doing every single job. And that's at buildings without outbreaks. So if we do have outbreaks and blanket testing, there's some unintended consequences of that. Still a good thing to try to find, but it's gonna lead to some staffing crises. Next slide. Main concerns, at least from my experience on the front line, is how are we going to live with this virus for the next, I would say, at least year? where nursing homes are going to be in constant lockdown and constant infection control mindset. And one of the major concerns that I have are the consequences of social isolation. So elderly people cannot be sedentary and have social isolation for very long before they start to physically and mentally decline to a point where they may not recover. And we're seeing it everywhere. So we need to quickly learn how to adapt and find the balance between good infection control and these draconian measures that we're implementing on nursing homes and keeping people in their rooms and not allowing any contact. And then the social distancing measures, as they are lifting now and we're seeing people get out and about more, we will see an increase in infections in nursing homes. It's just, it's guaranteed to happen. And so this is a major concern. How are we going to deal with additional outbreaks and our staffing concerns, PPE and so forth? So the staffing shortages. And then just a final note on if you'd like to do something for a nursing home, I get lots of requests from friends and family and my former school, hey, what can we do to help? One of the ways I've seen is effective is to give these boxes full of snacks, which are really appreciated by the nursing home staff. And they set them up throughout the building, and then you put your little thank you note on the box. So it's just a nice way to let them know that you're thinking about them. It's a simple thank you, and everybody appreciates it. So with that, I will turn it over to Dr. Palat.
Thanks, Travis. That does make sense to thank our frontline workers. Appreciate you. Can we start with the poll question? Great. Community dwelling older adults have a COVID-19 mortality rate around 15%. Older adults living in long-term care communities have a mortality rate around what? Thank you. Yes, so don't let the slide mislead you. It's a different question. But the poll question is asking about mortality rates in general. And in general, our nursing home patients do have a higher rate of mortality from COVID-19 compared to community dwelling older adults. And this is information that has come out of the King County, Washington data. The answer is not 50%, not yet, not now, because for now, we're really lucky that at least the majority of our nursing facility patients, just like in the community, are still experiencing mild to moderate disease. So it's not like 1 out of 2 people are dying from COVID-19. So that's good. But unfortunately, the data about prognosis in serious illness for COVID-19 is pretty poor. The Journal of the American Medical Association reported data from New York about patients who had been discharged from the hospital and who had required mechanical ventilation. That mortality rate is 88%. The bad news is that if you look at the subset of people who are age 65 and older, the number is higher. It's more like 97%. And of course, as you might guess, anyone who recovers from one of these serious illnesses is generally very weak and debilitated. They often can't function for themselves. The good news, if there is any, is that this data that was reported in JAMA only included people that had been discharged from the hospital. So at the time of publication, there was still a large number of people who were still in the hospital whose dispositions we don't know yet. So there's a chance this number will go lower. A New England Journal editorial had reported some information from New York also. They reported that their patients who had been critically ill, who had required mechanical ventilation and whose dispositions were known, 19 people died, 23 were discharged, so their mortality was 83%. And AMDA has reported from the critical care literature that frail older adults who require mechanical ventilation due to COVID-19 have a mortality rate of about 70%. So these numbers keep changing, and we're certainly going to learn more as we move forward. but the information is important for us when we're trying to discuss with our patients advanced care planning. It's good to have some sort of sense for our patients of what to expect and what is realistic. So the nursing home providers were called early on to review advanced care planning options with all of our residents again at the beginning of this pandemic. And basically by the first week of March, we were told that if we hadn't started advanced care planning, that we were probably behind. So if you want to do advanced care planning discussions, you can certainly use a form like the Colorado MOST form. And here's a picture of that. But since the pandemic has come out, there have been other advanced care plan tools and guidelines that are specific to COVID-19 that have been published. Today, I was on a webinar with Telegen, our local QIO, and they talked about the Conversation Project in Boulder, and they have great guides and tools on their website. The one I've included here comes from paltc.org, and it's a tool that guides providers how to have the conversation about advanced care planning, specifically regarding COVID-19. And I want to remind everyone that the goal for advanced care planning isn't to guide people to any one specific decision or another. The goal is to help honor our patients' preferences, to preserve their autonomy. And we also want to provide care that promotes their well-being and their dignity. So we want to preserve both autonomy and beneficence, and advanced care planning is a way to do that ethically. I'm going to tell you an example about one of my patients who I had the advanced care planning discussion with a few weeks ago. And what I did was go through the steps that are outlined here on this slide. My patient is 60 years old. He has end-stage multiple sclerosis. And for many, many years, he's told every physician he's ever worked with that he is a full core and that he would never change that. So 6 weeks ago, he develops a fever, cough, hypoxemia. And so among other things, I was very worried about COVID-19. And he was actually getting sicker each day despite the treatments we were providing him in the nursing home. So I had a conversation with his wife. The step number one is to determine the patient's medical decision-making capacity. And in this case, this patient with his end-stage disease hadn't actually had any meaningful communication for 1 to 2 years. And for 1 to 2 years, clearly his decision-making capacity was incapacitated. So the right thing to do, the legal thing to do, is to talk to his wife. Next, we talked about his goals of care. Many years ago, this patient had made his wife promise never to give up on him. So she wanted to make sure that he knew she had never given up on him. She wanted to make sure that every healthcare provider knew that she would never give up on him. So we talked about this, and I figured that after our conversation, the patient's wife would tell me, as she had many times before, that he would always be a full core. But this time, she surprised me. And I think that's because of step number 3. We talked about, and I provide some education about what would happen if he developed COVID-19. We talked about how there are no curative treatments for the virus, that if he required mechanical ventilation in his very debilitated state, he most likely would not do well. I assured her that if she chose for us not to send him to the hospital, we would optimize his medications. We'd treat his symptoms, just like Allison Villegas presented to us a few minutes ago. We would always take care of him in a familiar environment with familiar staff, even if it looked like he were dying. And I promised her, most importantly, that we would never give up on him. So she said, okay, make him a DNR. Don't send him to the hospital. So I documented the whole conversation, and that's step number 4, to document. In my reading, I haven't seen step number 5, but I think there should be one. The step number 5 should be to bill appropriately for the time spent on the visit. And actually Travis Neill, in addition to doing antibiotic stewardship, has done some research on this, and he teaches Colorado providers on how to bill appropriately for advanced care planning. And Medicare does have advanced care planning time-based codes that can be used on top of the regular E&M codes. So thankfully, my patient actually stabilized within a week with supportive care. He did not go to the hospital, and he actually didn't test positive for COVID-19. He had influenza. Now, my conclusion is this. I've been learning a lot, just like everyone here on this call and everyone on the panel, a lot about COVID-19 since this whole pandemic started. And the lessons range from little things to big things. A few weeks ago, I learned how to do nasal pharyngeal swabs. Like, I had never collected them before, not personally. And I didn't realize how far back you have to stick those swabs. And of course, now you can just submit nasal swabs. But here's a pro tip for you. If the lab loses your carefully collected swab, consider a chance to practice your technique again. For several years, I've been signing petitions for Medicare to try to repeal the 3 midnight hospital rule. So for someone to be admitted to a skilled nursing facility, that person has to have had 3 midnights in a hospital to be eligible for skilled nursing. Well, within 2 weeks of the COVID-19 pandemic, Medicare waived that rule. It was that easy, I guess. So I was really surprised. And frankly, with this patient that I just told you about, I was really surprised when he had spent so many years through his wife adamantly wanting to be a full core, as a response to COVID-19 chose to be DNR. But we are practicing in extraordinary times. I thank you all for joining us today, and I thank you for listening. This last slide shows you 2 websites, one from Foothills Medical Society, one from CMDA, and this recording of today's webinar will be available on those websites.
Well, thank you, Dr. Palat. We don't have any questions on the Q&A at this point. If anybody does have a question they'd like to ask, go ahead and just pop it in that Q&A. You can find it there on the bottom of your screen. If we don't get a Q&A, if we don't get any questions here in the next few seconds, we'll go ahead and just thank everybody for their time, and we'll see. I'll give everybody about 10-15 seconds if we get a question in. If not, we'll go ahead and call it a meeting. Oh, there we go. Got some people. Okay, let's see. Well, the first one's not a question. It's a very nice compliment from Jana Miller. This great overview. Thanks so much for taking the time. Thank you, Jana, for joining us. And then Shirley Turner. These are the best questions.
These are easy.
Far worse questions. Yeah, no questions. Just this. So thank you for doing that. Thank you, Shirley. I appreciate that. And thank you very much to all of our panelists for taking the time to get this information together and spending your volunteer time with everybody this evening. So. On that, if any of the panelists have any final words or comments, otherwise we can go ahead and adjourn.
Thank you so much for having us.
Thanks, everybody.
Yeah, thanks,
you.
Stephen. Appreciate it.
Bye.
Thank you. Bye-bye.